Anywhere from 12 to 25% of all sepsis patients actually develop sepsis in the hospital. So that's going to be, officially speaking, patients whose sepsis develops after at least 48 hours of admission. And those patients tend to be sicker. Even though they make up a minority of cases, they make up a greater proportion of deaths.
This is the Sepsis Spectrum, a podcast about antimicrobial resistance, sepsis, and how to expect the unexpected in your practice. Meet Severa resista. And for those listening, air quotes around Severa resista, not a person, but a problem. A pathogen forged not in the wild, but within the hospital environment itself. S. resista lives on hands, on surfaces, in the access ports of IV lines, and the corners of catheter hubs. Severa resista doesn't rush. It adapts. It's homegrown. Coming in with a patient, then given space to thrive. And once antibiotics are deployed, well, you know how that can go. Each course met with resistance, but not retreat. A fever, a spike in vitals. By the time symptoms appear, the damage is well underway. Hospital-onset sepsis emerges when systems falter, when documentation is delayed, when vital signs are missed, when teams are stretched thin. Awareness? That's the first step. Understanding how resistant infections take hold inside hospitals is the next. With that knowledge, perhaps next time, hospital-onset sepsis can be avoided. Hi, everyone, and welcome to the Sepsis Spectrum, or as we like to call this season, Microbial Mysteries. I'm Nicole, critical care nurse, clinical nurse specialist, and your guide through the complicated and sometimes frustrating world of sepsis and antimicrobial resistance. On today's episode, we're going to get a handle on how healthcare-associated infections, HAIs, are fueling both antimicrobial resistance, AMR, and hospital-onset sepsis, and why that's such a big deal for patients and providers alike. We're going to break down the major takeaways from the June 2024 CHEST publication on hospital-onset sepsis and why it should change how we approach infection control, antimicrobial stewardship, and treatment strategies. We're going to talk about the real-world impact of delays, whether it's slow rapid response activation or late antibiotics, and how those gaps can turn manageable infections into full-blown crises. We're going to walk through a tough clinical scenario involving HAIs, resistant bugs, and hospital-onset sepsis, using it to identify key risks and craft evidence-based solutions, including antimicrobial stewardship, amongst other things. And we're hoping you're going to leave with best practices you can apply right now, no matter your role, to help prevent, recognize, and manage HAIs, MDROs, and hospital-onset sepsis more effectively. I'm honored to present two guests today who are helping shift how hospitals respond to one of the most serious threats in patient safety, hospital-onset sepsis. Dr. Jennifer Ginestra is a physician and researcher at the University of Colorado, whose work is redefining how we recognize and respond to deterioration in the hospital. She focuses on the deadly consequences of delays, missed signs, and hospital-acquired infections, and what must change to keep patients safe. She is also co-author of Hospital-onset sepsis, a national patient safety challenge, which was published in CHEST, the Journal of the American College of Chest Physicians, in June 2024, which we'll be discussing momentarily. Dr. Emi Minejima is an infectious diseases pharmacist and associate professor at the USC Mann School of Pharmacy. She leads antimicrobial stewardship at Los Angeles General Medical Center and focuses on improving antibiotic use and outcomes for some of our most vulnerable patients. Together, they bring frontline insight into one of healthcare's most preventable crises and what it takes to fix it. Let's get started, and I hope you enjoy this incredibly memorable conversation with Dr. Jennifer Ginestra and Dr. Emi Minejima. All right. I'd like to welcome both of you to the show. So, Dr. Ginestra, would you mind telling us a little bit about what you do in the hospital?
Sure. First, thank you so much for having me. I'm excited to be here. I am a critical care physician, so I work on the medical intensive care unit. I also work on our critical care consult service. So I respond to rapid responses and critical care consults. And then outside the hospital, I'm also a researcher in health services and patient outcomes.
Great. And then, Dr. Minejima, would you mind telling us what you do?
I'm a faculty at the School of Pharmacy at University of Southern California, and my practice is at the LA General Medical Center, which is a safety net hospital in Los Angeles. So I'm an ID pharmacist by training, and I help run the antibiotic stewardship program at the medical center.
Great. Okay. So I'm super excited about this episode. We're going to talk about in hospital sepsis. And I know all of us have done a lot of work in identifying these patients and trying to kind of make sure they're on the right antibiotics and the right pathway. So, Dr. Ginestra, your research is mostly focused on in hospital sepsis. What exactly are you researching? And can you give us some updates on what's happening?
Yeah, so hospital onset sepsis is a really interesting entity in that it's a group of patients that tend to be very sick and have pretty poor outcomes. And they're a little bit challenging to study, but they're very important to study. So I'll distinguish hospital onset sepsis as different from what's called community onset sepsis, which is, I think, what most people classically think of when they think of sepsis. It's the patient that comes into the emergency room already with an infection, already septic. And that makes up the majority of patients who have sepsis. It's anywhere from 12 to 25% of all sepsis patients who actually develop sepsis in the hospital. So that's going to be, officially speaking, patients whose sepsis develops after at least 48 hours of admission. And those patients tend to be sicker. Even though they make up a minority of cases, they make up a greater proportion of deaths.
So, just in general, those patients don't do as well. And like, why do you think that is? Is it just because they're so sick, or are there other reasons contributing to that?
It's a lot of different reasons. They are kind of different at baseline. So patients with hospital onset sepsis tend to have more comorbidities like heart failure and renal disease. They're more likely to have cancer. They also tend to present differently with their sepsis in the hospital. So they are less likely to have typical signs and symptoms of infection like fever. They're more likely to have normothermia or even hypothermia. And they're more likely to have hypotension and hypoxia. Um, their infections tend to also be in slightly different locations, so they're more commonly going to have an intra-abdominal source in addition to the other usual sources, but more likely than someone coming from the community. And then the actual organisms that they're infected with, it's a slightly different group of organisms at different rates. So they're more likely to have staph, enterococcus, even fungal infections, Pseudomonas, and a little bit less likely to have infections caused by strep, for example. And overall, they have sort of a potentially a different immune response and other comorbidities that might come into play with their response to fluids, antimicrobials, things like that. I think the other big distinction is that there's a little bit more diagnostic uncertainty when a patient decompensates in the hospital as to what's going on than when they come in fresh to the ED with a clear story. So what we end up seeing is that these patients are less likely to get timely care. So it's probably a combination of the fact they're a little bit different at baseline. They have different patterns of infection and manifestations of infection and potentially a different immune response. And then lastly, that we're not quite as good at caring for them as we are in the emergency room.
So, what are you doing in your hospital to identify these patients?
It's a good question. So a lot of it is the usual bedside nurse and clinician sort of recognition and awareness. We also do have, I think, like many hospitals at this point, some degree of virtual monitoring and alert systems for big changes in abnormal vitals, things like that. But there's not really one particular alert system or early warning system that has been shown to be the right balance of sensitive, picking up all the patients you want to pick up so that they don't fall through the cracks, but also specific so that you're not alarming for every patient who's a little bit tachycardic when they get up to go to the bathroom. So we do have a rapid response outreach team that'll respond to the bedside when a patient's decompensating, but I think in general, we don't have very good predictive systems in existence yet to identify the right patients at the right time.
Yeah. And then, of course, this gets much more complicated when we throw in antimicrobial resistance. So, can you tell us, are we seeing more antimicrobial resistance now than we had been in the past? And first, I'll ask Dr. Ginestra that question, and then I'm going to ask Dr. Minejima.
Yeah, I think it's a little bit of a mixed bag depending on which organism you look at. Pre-pandemic, we were seeing some declines in things like MRSA and in VRE, vancomycin-resistant enterococcus. I think there was a little bit of a surge. There were some studies that suggest that there were more than expected numbers of multi-drug resistant organism infections during the pandemic. And I think it still remains to be seen exactly where things land in the post-pandemic era. Um, I think Dr. Minejima may know a little bit more with her expertise about the latest trends, but that's my understanding.
Yeah. And then, what are you seeing, Dr. Minejima?
Yeah, it's definitely in line with Dr. Ginestra. I think the CDC shows that compared to pre-pandemic levels, and the most recent data we have is in 2022, we still do see an increase in some of the hospital-onset multi-drug resistant organisms, or MDROs, most notably like CREs, some VRE, ESBL, definitely. So we're a safety net hospital. We're a little bit unique probably than compared to some of our private institutions in that we actually don't get a lot of SNF patients that get admitted into our hospitals. And our skilled nursing facilities are the air places where you have those frequent flyer patients that come in and out of the hospital frequently or colonized with MDROs in their gut. And so since we don't have those admissions, we don't have really high rates of some of these really nasty gram-negative rods like carbapenem-resistant Enterobacterales, but definitely we're seeing a pretty steep rise in ESBL producing gram-negative rods, which is problematic because typically what we reach for in terms of treatment of these ESBL organisms is a carbapenem, which we consider our biggest gun, very safe beta-lactam to use. The problem is that, of course, overuse of carbapenems, you're just running out of other safe antibiotics to use if you develop resistance. Just as Dr. Ginestra said, rates of MRSA have been declining over the last decade. Our population is very similar in that we've seen that similar trend. However, it has started to actually creep back up a little bit slowly over the last couple of years. I would say probably post-COVID. So that's something that we're just monitoring. So MDROs definitely are a big issue. Our rate of new antibiotics in the pipeline that have activity against these multi-drug resistant organisms is not robust. So it's really up to a lot of the clinicians and antibiotic stewardship programs to think of interventions and unique methods in order to preserve a lot of the things that we are already using. So we have very strong infection control at our health system and to make sure that we can identify patients that have colonization with MDROs, making sure that that's alerted to both the clinician, the nurse, and antibiotic stewardship so we can monitor these patients closely. But also if something happens where they do have signs of sepsis during the admission, that we use our knowledge about specific known resistance mechanisms or known colonization from these patients in order to come up with the best empiric therapy for these patients.
And what are you finding now? Are a lot of clinicians using antibiotograms, do you think, pretty routinely across the country? Or are we still seeing a lot of variability in practice? If you had to guess.
Definitely variability still, I would say. So I think definitely your resource-rich settings with a very strong antibiotic stewardship program that's long-standing, they typically have the FTEs or full-time employees that can staff antibiotic stewardship to help guide clinicians on the front line with appropriate empiric choices. They also have the staff to develop, a care pathway or empiric guidance that is tailored to a specific ICU or tailored to the specific institution, which is really important because every hospital is different. They carry different formularies, they carry different, patient populations, which result in different types of MDROs, different antibiograms. So taking the national guidelines and tailoring it to your specific site is really important. But sometimes, if you have a very, a stewardship team that's in its infancy, they might not have had the time or the expertise to develop something that is very fine-tuned to their specific patient population. In addition, typically the large academic medical centers are the places where you might see a long-standing antibiotic stewardship program that's well-staffed and a very multidisciplinary antibiotic stewardship team. But perhaps when you get to those smaller community hospitals or rural hospitals where they don't have the FTEs, they may not be able to hire an ID pharmacist or an ID physician or a critical care physician, critical care pharmacist with expertise on, okay, what are the types of infections that you see in your specific population? What are the types of resistance, patterns that you see, and developing a empiric, guideline pathway specific to that institution, because Dr. Ginestra's paper, you're looking at hospital-onset sepsis, really highlighted these patients are different, and it is sometimes very difficult to pick up. Okay, when is that time zero? Right? When do those patients start exhibiting those symptoms? And then you have an hour to get the right antibiotic into them. And that's not a lot of time because, you have to think of the physician at the bedside making the assessment. They have to put in the antibiotic order. And then the pharmacist has to verify that order. Then there's many other steps that probably most don't know about in that, the order gets put into the pharmacy. A technician has to notice that the order is there. They have to, depending on the availability of a ready-made antibiotic versus something that they have to compound. Then, the technician has to get the pharmacist to check off to make sure that it was compounded correctly. Somebody has to run up that medication to the nursing station. And then the nurse has to know the medication is ready to hang at the patient's bedside. So there's actually a lot of steps that go on from when the physician at the bedside notices sepsis, puts in the antibiotic order, to the time the nurse actually can hang that antibiotic order. And doing all of those steps within 1 hour is really challenging. And, that's something that our institution has really struggled with. So, you know, it takes a village and with a big multidisciplinary group to make sure that each patient, from sepsis recognition to getting that antibiotic into them, work together to come up with interventions or a pathway that is going to be the most conducive to the existing workflow, and making sure that there's appropriate follow-up after, and that de-escalation happens, appropriate durations, follow-up on cultures, things like that happen. So it's definitely it can be challenging just based on whatever setting you're at. And so yes, long story, but there's a lot of variability in terms of what an antibiotic stewardship program and a sepsis team might do in order to improve how we deliver antibiotics to a patient.
Yeah, and Dr. Ginestra, do you see in the a future that includes AI to help us identify these patients that are already hospitalized and getting sick in front of us? Or what does the future look like, do you think?
I think it definitely is going to play a role. I think that we've already been, I don't know, maybe 5-10 years into a number of groups trying to develop, AI is sort of a big umbrella term, but I'll say in the, more specific statistical term of machine learning algorithms. So you're really using advanced methods to identify patients and patterns of patients that maybe harder for us to identify based on a few criteria, uncover patterns that maybe aren't as obvious on the surface so that we could try to figure out which patients truly need our help. And a lot of the reasons that some of our alert systems that have been implemented in the past have failed are because the sensitivity specificity question that I brought up earlier, we're either alarming on far too many patients without a lot of specificity. So you're showing up to the bedside for a lot of patients who aren't septic, or we're not specific enough to the patients who truly need our help. And so the question is, which patient is going to get sick and not be noticed? Which patient is going to get sick and actually have delays in care? And then which patient is actually going to be harmed by those delays? And which patients need X approach to treatment and which ones need Y? Which ones would benefit from a more aggressive fluid resuscitation strategy and which ones would benefit from a more conservative vasopressor forward strategy? And that's, I think, where things are hopefully headed, is using AI and machine learning to try to understand the heterogeneity of these patients. Because we call sepsis a syndrome, we kind of call everything sepsis as if all the patients are nails and we just have the one hammer. But it's actually a big variety, I think, of underlying immune systems, patients, comorbidities, and bugs that we're dealing with. And potentially different phenotypes of how that manifests in patients. And so I think that's where hopefully AI will be very helpful, is to uncover those patterns, help us identify high-risk subgroups, and then help deploy teams to the right place without interfering in workflow or adding alert fatigue and things like that.
Yeah, I'm excited to see where it does go and how long it's going to take us to get there. But I really do feel AI is going to play a role. All right, so we're going to go to a quick break, and when we come back, we're going to dig a little deeper into hospital-acquired infections, antibiotic drug resistance, and just what do we do differently in hospital-acquired infections. Are you a nurse, infection preventionist, or healthcare professional who wants to stay ahead of the curve? Visit sepsispodcast.org to learn how you can receive free nursing CE credits by listening to or watching the Sepsis Spectrum. It's our way of supporting you and together better understanding the ever-evolving world of sepsis care and AMR. And now, back to the show. Welcome back. So, Dr. Ginestra, I want to talk about the paper that you were an author on. It was published in June of 2024 in Chest, and it specifically addressed hospital-onset sepsis. What takeaways from that paper do you think would be helpful to anyone working in a hospital that's listening in?
Yeah, so the paper that we wrote, our goal was really to highlight this entity as kind of a distinct clinical entity that at least warrants more research, if not potentially different management than what we're doing for sepsis historically for community onset sepsis. And what we wanted to highlight was that it has not been studied very extensively. The vast majority of research in sepsis is in that community onset group. That's where all the sepsis trials have been, and a lot of the observational research as well. And there's certainly a growing interest and body of literature in hospital onset sepsis, but there are a ton of knowledge gaps, a ton of things that we just don't know how to deal with. So even how we identify cases in retrospective research, the clinical heterogeneity that we spoke about, how we understand different subgroups, and is this something that's truly distinct from community onset? Is it just a different phenotype? Also, management decisions. Should we be doing the same things for these patients? Because a lot of those trials, like I said, weren't studied in hospital-onset sepsis, and we know those patients are a little different. There's also prevention issues that I think are very relevant to what we're talking about today that have to do with all of the hospital-acquired infections that lead to sepsis don't have necessarily robust prevention efforts around them equally. And we can get back to that. But the other sort of big questions are, how do we ensure that the care that we deliver for these patients is equitable and patient-centered, so that at the end of the day, for these patients who have a pretty high risk of mortality, a good proportion of them have potentially a terminal illness like cancer. How do we make sure that we are doing the best that we can to prolong their survival, but also to ensure their quality of life in that. And to make sure that that escalation of care to the ICU, invasive procedures, all of that is still in line with their ultimate goals. So there are a lot of different areas of sort of growth that we still need clinically and in research in this space. And that was the point of that paper, was really to highlight that need for awareness and work in this space.
I mean, because it's complicated. It's extremely complicated because you've got somebody who's already sick and
Hmm.
then develop another issue while they're hospitalized. So let me ask, at what point do you get Dr. Minejima involved? So Dr. Minejima is a PharmD who's got a specialty in infectious disease. When do you get someone with her specialty involved?
That's a great question. And so, like we talked about, patients with hospital-onset sepsis are more likely to have drug-resistant organisms. So if you look at patients with community-onset sepsis, about a quarter of them might have a drug-resistant organism. But in hospital-onset sepsis, it could be up to half of patients with a bloodstream infection developed in the hospital have a resistant organism. And so you're talking about using broader antimicrobials to cover these and potentially more challenging situations where that diagnostic uncertainty comes into play. You're trying to figure out, is this hospital-acquired pneumonia and sepsis, or is this a heart failure exacerbation or iatrogenic volume overload? So there may be questions diagnostically about whether this is the right diagnosis, and then there are often questions about coverage that come up. So I would say that when to get them involved, well, upfront, your empiric coverage should ideally cover the main risk factors. So most any patient who develops sepsis in the hospital is going to need pseudomonal coverage. So that's going to be your fourth generation cephalosporin, cefepime, or piperacillin tazobactam, which may be different in your health system. I worked in a health system before where cefepime was the drug of choice based on our pseudomonal sensitivities, and I currently work in a health system where pip/tazos are drug of choice. So whatever is in your system is the best choice for anti-pseudomonal. Then you're probably going to want anti-MRSA coverage as well. But then beyond that, you need to think about risk factors for other drug-resistant organisms, VRE, ESBL, CRE. You need to think about risk factors for C. diff, and those are individual to the patient. And those risk factors are listed in society guidelines, but hopefully are also part of your antibiotic guidelines in your health system. Those would include things like long-term indwelling lines, prior colonization, prior IV antibiotic exposure in the last 90 days. For some things like ESBLs, even travel to or hospitalization in an endemic region. And there are tools online to help you find that. So some of those empiric choices up front can be guided by those risk factors. When I start to get people involved is if a patient has a complicated prior microhistory. So if they've grown multiple bugs in the past that have different resistance patterns, or they are now growing a bug that has a challenging resistance pattern, or they're getting worse and I don't know why. So basically, if you need help, have a low threshold. And you're not wrong to ask upfront with your empiric coverage as well, to just check in with your ID pharmacist, your antimicrobial stewardship team, to make sure that what you're choosing is appropriately broad to cover their risk, but not inappropriately broad, because both ways have risk.
Yeah, and Dr. Minejima, now let me ask you that question because I'm sure there are very limited people with your specialty. So how would you answer that question? When should infectious disease get involved?
Yeah, so at our institution, we actually have two different services. We do have the traditional ID consult. So that is when, if Dr. Ginestra wanted a formal consult from an ID specialist about a very complex patient, they would go see the patient at bedside, make recommendations, and follow the patient. We have a separate service, antibiotic stewardship service. And so we actually are monitoring all patients on antibiotics, especially in the ICU, usually more in the background. So usually we are monitoring, a list of priority antibiotics. So for our institution, we choose things that are broad spectrum beta lactams. We also have a restriction policy on certain antibiotics as well. So we prioritize what our eyes see for any patients in the ICU on a daily basis. So, the ICU team may not necessarily know that we're following their patients along with them, but we're usually in the background. If we do notice that there might be room for maybe optimization of anything related to their antibiotic therapy, we'll typically call the ICU provider, try to have a discussion as to, what they see, because obviously we're only doing chart review. And so what they see at the bedside may not necessarily translate into what we're seeing just from chart review. So we want to have that discussion with them, and then come up with a plan that is, of course, something that the ICU provider is comfortable with. We're never trying to shove down anything, tell them how to prescribe, but we're just there as a resource. And so for our institution, we've had this longstanding, daily stewardship rounds for several years. So a lot of our teams, both medicine, surgical, ICU, they kind of expect our phone call on a daily basis. And so it is more of a collaborative discussion. However, when we were ramping up to this point, they did not like us. Or, it wasn't as received because they thought that we were trying to, take away their prescribing autonomy, which it was not. That was not the purpose. We're all there for the same purpose, just to optimize how the patient is, their potential outcome when they're in our hospital with infection. So it was a gradual process that we worked up to, and now, we're at a current at a great place with a lot of our providers. And we're actually now having the reverse effect where sometimes a lot of our trainees aren't thinking about, okay, what is the best empiric regimen for this, their patient in front of them. They've just got in the habit of calling us and asking, okay, what do I do for this patient? For every single one of their patients. So, there's some pros and cons to being a very available service for any type of, I guess, more of a curbside that typically our full ID consult team may not be available.
Well, I wanted to just chat just for a couple of minutes about extended administration of a lot of the antibiotics we're giving. Piptazo has been one of those drugs we've been giving, on an extended administration. Do you see other drugs getting added to that type of an approach of using extended administration?
Yeah, I mean, theoretically, when you're trying to optimize pharmacokinetics and pharmacodynamics of a drug, piptazo, carbapenem, they're a class of beta-lactam. They're within a class called a beta-lactam class. So theoretically, you could do that to any beta-lactam to optimize their pharmacokinetics and pharmacodynamics. The challenge with that, there's many. And the main thing, though, is that it doesn't necessarily improve mortality outcomes or survival benefit in all of your patients. And so the approach that we've taken is that we actually do not do an institution-wide extended infusion policy for piptazo or meropenem, but we do it on a case-by-case basis
Oh, okay.
based on the patient, the severity of illness, the type of infection they have, and the organism that they have. Which is different than many other institutions. They take an approach to just make it a system-wide policy that any piptazo or carbapenem order is always going to be extended infusion. So it is up to the institution on how they want to administer it. The main thing with us is that we had a policy that was approved, but we had so much pushback after implementation that we decided to kind of roll back the requirement to make it an extended infusion for all.
Got it. So can you just give us a quick example of like patient A and patient B, like which one you would do an extended infusion approach?
Sure. Yeah. So patient A is a community-onset urinary tract infection here for likely an E. coli urinary tract infection. This patient is going to be fine with just giving, ceftriaxone or another beta-lactam intermittent infusion. They have a low risk for mortality. They're likely going to respond very quickly to a couple doses of antibiotic, and then they're going to be able to be discharged from the facility with continuation with oral antibiotics, likely to finish out at home. Separately, you have patient B. Patient has been hospitalized for over 48 hours, initially for an MI, subsequently develops pneumonia symptoms, and we're worried about ventilator-associated pneumonia. 48 hours later, vent settings are not improving. isolation of Pseudomonas aeruginosa in the BAL culture, and we noticed that the MIC to cefepime or carbapenem was on the higher range. And so because of the severity and illness of the patient, the high MIC, and the knowledge that Pseudomonas aeruginosa VAP is already difficult to treat, we decided to give him high-dose carbapenem at an extended infusion as well in order to maximize the pharmacokinetics and pharmacodynamics of the organism, of the bug-drug combination, and then improve their chance for survival.
So can you just for those of us who aren't aware, can you just explain, is the MIC reported when cultures are done, or what does that look like?
Yeah, so usually, and of course, this practice also does vary based on institution, but at ours, when you do a standard culture and susceptibility test and the report becomes available in the electronic medical record, you'll see the source. So whether it was blood versus urine versus respiratory culture, it has your list of antibiotics that organism was tested against. It usually has the actual MIC, minimum inhibitory concentration, for that bug drug pair. And then it has the MIC interpretation. So if a Pseudomonas to cefepime pair has an MIC of 2, do we consider that susceptible, intermediate, or resistant? And that report is usually available per patient in the chart. There are some institutions that decide not to report the MIC because, unfortunately, it is interpreted incorrectly a lot of the times. And so all they give is the MIC interpretation. So if it's a susceptible, intermediate, or resistant pathogen.
Dr. Ginestra, are you seeing a similar approach in your facility with extended infusion of antibiotics and MIC reporting, or what are you seeing clinically where you work?
Yeah, I would say it's similar. We do have the MIC and interpretation reported. In terms of extended infusions, I don't think that that's really taken on fully. It's the sort of thing that, on a case-by-case basis might be recommended by the pharmacist in particularly challenging to treat cases. But I think for similar reasons of administration complexity of having a longer continuous infusion, it's not. And I would also say some of the data being a little bit mixed as to the survival benefit, that hasn't taken on a universal approach to our care in our facility.
Yeah, I think a lot of nurses will be happy to hear that there are some facilities that are approaching this on a case by case, because it ties up an IV line for a lot of hours out of the day, and it can be very challenging. Yeah. So, Dr. Ginestra, I wanted to ask, which hospital-acquired infection does CMS not require reporting for, and why not? And why does any of this matter?
Great question. So hospital-acquired infections are infections that you develop in the hospital, and there are two main bodies that track these in the U.S. The first is the National Healthcare Safety Network that tracks these mostly for surveillance, and it tracks a lot of hospital-acquired infections. The second is CMS, the Center for Medicaid and Medicare Services, which will require all hospitals to report a certain subset of hospital-acquired infections quarterly, what their rates are. And that's not every hospital-acquired infection, but it's a certain key few. So the most common, the CLABSI, central line-associated bloodstream infections, CAUTIs, catheter-associated UTIs, also MRSA bacteremia, C. diff infection, and certain surgical site infections. And they track those not only to be able to report public quality metrics, to be able to compare hospitals, but also they tie those rates and quality metrics to reimbursement through Medicare reimbursement rates. So they'll penalize hospitals if they don't report. They'll penalize hospitals that fall into the lowest 25% of very high rates of hospital-acquired infections by reducing their reimbursement rates across the board, not just for sepsis. And then in 2008, Medicare actually also introduced a non-payment type rule where if a patient develops a hospital-acquired infection, they won't pay for that higher complexity DRG that they might have ended up with. They'll just pay for what they initially came into the hospital with, and they won't reimburse for anything that has to do with that hospital-acquired infection. So all of that is to incentivize hospitals and healthcare systems to implement surveillance and prevention strategies to really get those rates down, which has worked in the sense that a number of those acquired infections have improved and gone down. I think the piece that's challenging here is that there are other infections that you can get in the hospital that are not one of those. So that would be things like ventilator-associated pneumonia is tracked, but it's not tied to reimbursement. Non-ventilator-associated pneumonia, anything that isn't tied to a device, basically. So UTIs that aren't from a catheter, bloodstream infections that aren't from a central line, things like that. Other skin and soft tissue infections are not tied to reimbursement, not tied to these quality metrics, and therefore not tied to these incentivized prevention programs. The other piece is that we then can't compare which programs worked because we don't have mandatory reporting across hospitals to say, oh, you implemented A, hospital B implemented B, and one of these worked better than another. So it's an interesting policy space that starts to influence what healthcare systems are doing to prevent these infections. And where it really matters for hospital-onset sepsis is that the reportable sort of classic hospital-acquired infections of Klebsiella caudis, C. diff, et cetera, only account for 14% of hospital-onset
Oh,
sepsis cases. So that
I didn't
leaves
realize that.
86% of
Wow.
these hospital-onset sepsis cases are from an infection that's not tracked by CMS. Um,
Oh.
which means that there's a lot of room for improvement in these other things that get less attention. And there's a reason that they get less attention. Part of it is CMS is trying to track things that are theoretically potentially preventable because they're device related and it's much easier to just remove a device or have sterile technique to insert it, that sort of thing. It's much harder to prevent non-ventilator associated pneumonia because then you're talking about working on delirium, dysphagia. Those things are much more challenging. They're also much harder to identify in a standardized way because we just don't have as standardized of criteria for identifying those cases. It would require a much higher burden of data collection, going through charts and that sort of thing. So there's reasons why they're not necessarily tracked the same way and not tied to reimbursement the same way. But I think a side effect to be aware of, one for clinicians when we're talking about hospital-onset sepsis, it's not just Klebsiella and caudis, it's a lot of other stuff. And then two, from like a healthcare leadership perspective, there may not be the same motivation or funding for these prevention efforts for those other groups of infections, but it doesn't mean that they're less important or that they won't have as big, if not bigger, of an impact on the case fatality rates.
Wow. I honestly did not know that statistic about CMS and
Yeah.
14%. I'm just a little mind blown right now.
Yeah.
Wow.
And if you include ventilator-associated pneumonias, which is another sort of classically tracked, and a lot of hospitals do track that, it's just not tied to reimbursement. If you include that, we're still only at like 28% of cases. You still have 3/4 of hospital-onset sepsis cases that have nothing to do with what we classically think of as hospital-acquired infections.
Dr. Ginestra, can you talk a little bit about the role of the rapid response team and just assisting with identification, treatment, strategies for patients who do have hospital-acquired infections who are deteriorating?
Yeah, it's a challenging space because there's definitely some data that suggests that rapid response teams improve care in the sense that they help patients get blood cultures collected more quickly, get antibiotics more quickly, potentially a higher level of care, ICU transfer more quickly. And in some cases, it's been shown to improve outcomes as well. Although the data, I would say, in rapid response team activation is very mixed. Part of that is because there's about 1 billion ways you can design a rapid response team. There's all of the efferent arms, so basically all the information that feeds into triggering a rapid response. There's a lot of variation on what might trigger it, what your threshold is, how you're monitoring those things, who can activate it. Then there's a lot of variation in the afferent arm, so what actually gets deployed, who goes to the bedside, what are they doing? And there's actually an interesting study out of Cleveland Clinic a few years ago that showed that they had really no change or even kind of a worsening in their outcomes after deploying a rapid response team. Then they made some changes to it and it improved outcomes. It really was a helpful demonstration that it's not just having one, but it's how you do it and what it does that matters. And so there's probably not a one size fits all of what is the best fit for a rapid response team to help. But I would say that in hospital onset sepsis, the place where that can be really helpful is, again, a lot of times rapid response teams will have a nurse, often a critical care certified nurse, who is deployed and can get an IV, help start fluids, start antibiotics, obtain cultures, obtain labs. Sometimes you'll also have a nurse coordinator or a critical care physician or other physician who can help kind of get the big picture of, does this patient warrant a higher level of care? Does this, what is on the differential for this patient? Kind of take a step back and think things through. So I think particularly when we're talking about these cases where there's diagnostic uncertainty, it can be helpful to not only get things moving, but to get some new eyes on the situation, and potentially some experts as well to help think through what's most likely and get things moving.
Dr. Ginestra, I just want to wrap up the episode by asking, what 3 points or takeaways would you give to other clinicians who are working in a similar space as you and treating patients who have hospital-acquired infections?
Yeah, I would say that the first is that hospital-acquired infections can lead to hospital-onset sepsis. About a quarter of those infections will lead to sepsis. But that's not the whole picture. Those traditionally reported infections account for only a small amount of those hospital-onset sepsis cases. And so for clinicians to be aware of that, patients can develop sepsis in the hospital, not just from the CAUTI, the CLABSI, the classic things, but also aspiration pneumonia, other skin and soft tissue infections, even a bloodstream infection without a catheter. So I think that awareness of those risks, and then also awareness from a systems level that these are additional sources of infection and risk that need to be addressed with prevention strategies that don't necessarily have prevention strategies as robust yet as we do for things like CAUTI and CLABSI. The second would be just knowing that patients with hospital-onset sepsis are different than the patient coming through the ED. They tend to be higher risk. They might manifest sepsis in a more subtle way. And the diagnosis may be less certain up front, but they do have a high risk of needing ICU, needing mechanical ventilation, needing pressors, and a high risk of death. And they also have a high risk of drug-resistant infections. So in starting their empiric therapy, you want to be thoughtful about their severity of illness as well as their risk factors. So usually you're going to be covering Pseudomonas and MRSA. You also need to think about risk factors for other drug-resistant organisms. And also think about things like fungal infections and C. diff, which patients in the hospital are going to be more at risk of. And then in choosing that empiric therapy and continued therapy, engaging with your antibiotic stewardship teams and your pharmacist and using your local antibiogram, really pull in those experts because these cases aren't as straightforward as the patient coming from the community. And then the last piece is going to be that de-escalation is key. So there are risks to not covering the patients broadly enough, but there are also risks to covering too broadly and leaving patients on big gun antibiotics that they don't need. So really make sure that you get blood cultures drawn, check things like a MRSA NAIR screen, check a procalcitonin if your suspicion for infection is low and you think it's going to have a good negative predictive value, and use those tools to help you de-escalate as soon as you can.
Okay, I think that is amazing. That's some great advice. Now, Dr. Minejima, I'm going to pose this question to you. So if you could offer a few points of advice to clinicians, especially in these complicated patients, what would be some parting thoughts from you?
Yeah. I'll take a approach from like a ID pharmacist or maybe a non-frontline staff approach. Some tips definitely is these these patients obviously are unique. So what can you do to aid the clinician to make that diagnosis sooner? And then what can you do to help them get the right antibiotic sooner? So obviously trying to have a robust infection control to prevent any of these hospital-acquired infections is going to be really important. So collaboration with infection control department is going to be important between infection control, ICU, and also antibiotic stewardship. And then from an antibiotic stewardship perspective, can we come up with other unique strategies in order to make getting that first antibiotic dose to them sooner? So there's, interesting work and using AI, machine learning models, like the Inspire trial. Of course, this was done in the non-critically ill, but using machine learning to figure out in your patient population who is at risk for MDROs, so that you can try to tailor who gets the carbapenem versus maybe who gets the ceftriaxone when they had that onset of sepsis. Second is, okay, can you create certain things in the EHR to make it easier for the clinician to order the right antibiotic for the patient? So there's a lot of investigation into order sets. Of course, making sure that you provide education, I think, is a big part of antibiotic stewardship, especially at larger academic centers. Every July, we have to have that same education piece to our new interns that are coming in about the importance of stewardship and how it really is everybody's responsibility to utilize the antibiotics in an effective and safe way for our patients.
Yeah, it is definitely complicated. And I just want to thank both of you for coming today. You both are experts in your field and just sharing your knowledge. And I think a lot of helpful tips that other clinicians will be able to use at the bedside.
Thank you for having me.
Thanks.
Boy, those were some complicated topics we just chatted about. And we all know recognition of hospital onset sepsis is very, very difficult. It is so hard to identify when you've got a patient who's already sick and gets sicker. And then that often ties into antimicrobial resistance. So I just want to thank Dr. Ginestra and Dr. Minejima for just talking about these complex issues. Thank you for joining me on today's episode of the Sepsis Spectrum. If you like the show, we want to hear about it. Please leave a review wherever you're enjoying the podcast. It helps a ton. You can also reach me and our awesome team at info@sepsis.org or visit sepsispodcast.org to share any stories of your own, questions, concerns, or episode ideas. To learn more about Sepsis Alliance, visit sepsis.org. The Sepsis Spectrum is brought to you by Sepsis Alliance. I'm your host, Nicole Kupchik. Our executive producers are Allison Strickland, Hannah Sass, Claudia Orth, and Alex Colvin. Our producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Nicole Kupchik. Our post-production producer is Tim Scott. Our editor and engineer is Jason Portizo, and our music is by Omer Benzvi. To learn more about Sepsis Alliance's podcast legal disclaimer and compliance policies, you can visit sepsispodcast.org/disclaimers. The Sepsis Spectrum is a Human Content and Sepsis Alliance production. Thanks for watching. I hope you're enjoying the Sepsis Spectrum. Leave a comment below and let me know. If you want to binge some more episodes, just click that playlist right over there. And if you're feeling super generous today, give this video a like, subscribe if you haven't, hit the bell, all the things. And of course, you can also listen on the go wherever you get your podcasts. Bye.